Okay.
Looks like we have 30 people already here. They'll be coming in. You can watch your participant screen there, and I'm going to stop talking. I'm going to mute myself now.
Okay. All right. Good morning to the people who have logged on already. We have, I think that says about maybe about a quarter of the number of people who signed up. I don't know how many will actually be here, but that's how many signed up. So we'll wait a couple minutes to give everybody a chance to log in, and then we will get started with introductions and so forth. Just to remind you, this is a webinar, so you're not going to be on screen. Only people on screen are going to be us. And if you have questions you did not submit already, if you want to type them into the Q&A, you can do that. I don't know that we're going to get to them. There's so many questions, we're not going to get to all of them, but we'll do a good job, we hope, of answering kind of the most common questions that have occurred, okay, that have shown up. As somebody has already noticed, you can turn on closed captions if you would like to not have to listen to all of us and just read what we're saying. You can also make us be invisible so that you don't have to look at us. That would be fine too. Marsha, you might want to hide your visual too.
Okay. I will as soon as you start. I'm just, you said you were going to introduce me, so I was going to say, hello, good morning.
Yes. Okay, I will do that. All right, so how are we doing here? We've got let's wait another like 1 minute, and then I will introduce, oh, there we go. And then I will introduce our speakers as well as the association itself. I'm going to remind me and our two speakers that if we need to take a drink or something, we're going to go off screen for a moment, which I'm going to do right now. I will be right back. Okay, I think we're about time to get ourselves started here. So let's make sure that our panelists you can hear, right? Okay, good. And I know we can hear you. So let me start out by introducing myself, the association, and our association's founder. I'm Dr. Jaelline Jaffe. I've been involved with the Misophonia Association since the beginning, which was in 2013. I have presented at all of the conferences that we've had, the conventions we've had so far, which has been 10, and many of these clinics. Just a reminder to all of you who are online here, these discussions are recorded and they can be found at the Misophonia Association website. There are also recordings of all of the convention presentations that you can find there, and you can sign up to have access to all of them for a very modest fee. These discussions, the clinics, are at no fee. We hold them quarterly, so the next one will be probably around March, and then another one around maybe June or so. And then we have our annual convention, which will be in October, November, somewhere around there. And we invite you to participate to whatever degree you're able to all of those things. Just a reminder, you can use the closed captioning feature if you don't want to listen to us, and you can also make us invisible if you don't want to look at us. All right. I'm going to introduce now Marsha Johnson, who is the person who established the Misophonia Association. She's our founder, and she's actually the person who originated the name 4S, selective sound sensitivity syndrome, in the late 1990s, before the cute little name misophonia showed up, and that one stuck, even though it's a misnomer. As we all know, misophonia is not a hatred of sound, but that is what that word literally means. So let me introduce Marsha for a moment so you can get to know her. She's going to do all of our tech today. Go ahead, Marsha.
Dr. Tech, bye-bye.
Okay. That was fast. All right. All right. So now I would like to introduce, or allow them to introduce themselves, our two panelists today. We have an audiologist as well as a therapist, which I think, in my experience, is an ideal match. This is the best way that I know of to help people with misophonia, to approach it from those both angles. So let's start with, on my screen, I happen to see Lisa. So Lisa Fox Thomas, how about if you introduce yourself? Tell us who you are, where you are, what your connection is with misophonia.
Great. Thanks, Jaelline. I'm Lisa Fox Thomas. I am an audiologist and I work at the UNC Greensboro Speech and Hearing Center in Greensboro, North Carolina. I've worked there for about 20 something years and have been working with misophonia patients for the last 15 years or so. I specialize in auditory processing and tinnitus and sound sensitivity, including hyperacusis as well as misophonia, and work with both children and adults. I approach misophonia from an audiological perspective, which we'll talk about a little bit more, which includes some informational counseling, not to be confused with the type of counseling that therapists offer, as well as sound therapy, and we also do offer some other types of approaches, such as biofeedback, that have proved to be very helpful for our patients. So look forward to chatting with you some more.
Okay, I can jump in, Jaelline.
Yes, please.
Okay,
By the way, my name is pronounced Jaelline, and
Jaelline.
I didn't say that at the beginning correctly. Okay, Jaelline, go
Jaelline,
ahead.
Thank you,
Caroline.
Jaelline. Thanks.
Caroline.
All right. Yes, I am Caroline Seligman. I'm a therapist, and I'm so happy to be here today. First of all, I just want to express my gratitude for everyone that's joining today. We have such a huge population of people that are affected by misophonia, and it's just wonderful to have a community. So I just want to just thank everyone for being here first. But yeah, a little bit about me. So I have a small private practice in upstate New York, and I focus on people with misophonia. That's become my kind of a specialty that's developed over the past couple of years. I myself actually have misophonia, and when I entered grad school in 2010, I went in with a specific interest to see if I could understand this thing. And so I studied clinical social work, but I focused on neuroscience research and its implications on various treatment methods and modalities. And that stuck with me. So my practice really focuses on not only the mind and what we know about neuroscience, but also how misophonia affects us physiologically, our nervous systems, how we feel the responses in our bodies. And so that is a part of my work too. There is definitely somatic elements, but I use a combination of acceptance and commitment therapies, psychodynamic approaches, polyvagal theory, and I'm trying to think if I'm missing anything. I usually see people remotely. That seems to work pretty well for folks. And yeah, just really glad to be here. Thanks,
Great.
Jaelline.
Okay, thank you. So the way we're going to proceed is there were a number of questions that were submitted when people registered. I have grouped them into sort of categories to try to cover the most common questions that were raised. One that was not raised, but often is, and I just want to address it right now, is for those of you parents who are concerned, can my kid function in life and be successful? You just heard somebody say, I finished graduate school and I'm a licensed professional and I work in this field and I have misophonia. So you give yourself a little hope and don't be so worried about whether your kids are going to be able to make it. They are. Now, moving into one of the main categories that many of the questions came to is one that we are probably going to address very minimally. That is, what causes misophonia? There were questions about, is it genetic? Are there studies that have to do with gender and ethnicity? Does it have anything to do with growing up with narcissists or trauma? There are all those kind of questions that got posted. And I'm going to address all of them myself, and then we'll go on, which is to say, we don't know what causes misophonia. There is ongoing research, and one of the people who asked a question wanted to be involved in research, wanted to know if there are any opportunities to do that. And the answer to that is yes. There are many research studies going on, and we can provide you with contacts for the people who are conducting those studies at various universities around the world. That's the end of that subject. We're going to move on to, so what do you do about it? There were many questions that have to do with coping. How do we help individuals with misophonia cope and manage? And we have more than one way of approaching that. So let's start. Since misophonia initially was thought to be an audiological disorder, there are audiologists who got involved in helping with this. So let's see what Lisa has to say about how audiology can help with coping.
Yeah, happy to. So yes, I do think that there is an element of auditory processing involved in misophonia, even though we know that it presents sometimes in more than one modality. There are also visual types of triggers for some people, but we do believe that for at least the majority of people with misophonia, that there is some sort of way that we can support them from an auditory perspective. And so usually that involves sound therapy. So we use sound that people like, sound that is not threatening, sound that is somewhat neutral, if you will, to help them with sounds that are bothersome. And the main objective of sound therapy is to help people remove barriers from being in situations that are triggering, to help them be more comfortable so that they're not as isolated or that sound is not as impactful. And ideally, over time, as maybe they become less worried about sounds, they may even find themselves not needing to use sound therapy as much. And maybe some of the sounds that bothered them more in the beginning don't bother them as much anymore. But the goal with sound therapy is to help people be in the presence of sounds more comfortably. And there are different ways to go about that. I know a lot of people will use earplugs as a way of avoiding sounds, and that's another discussion that we can have, the pros and cons of that. But the thing with earplugs is that it may not provide enough, I guess attenuation would be the best word to use, but it may not completely help a person not hear the sound that's bothersome to them. And it also, of course, when they take the earplugs out, the sounds are still there and they may even seem louder to them because they've been wearing earplugs for a while. So we don't want to increase someone's sensitivity to sound by having them avoid sound too much. So the way that sound therapy works is that you can use environmental sound or more optimally some sort of ear level sound that would help someone not notice their bothersome sounds as much. And over the years, I've been able to sort of, I guess, develop an approach that has been more effective at helping people use sound therapy that is somewhat shaped in a way that it can help minimize their awareness of sounds. It may sound, you've probably heard of things like white noise and pink noise and brown noise, but what I have found is that not one noise will work effectively for all different trigger sounds. And so it's really helpful for people to have the sound that is best for them for that particular trigger or in that particular situation. So there are ear level devices that people can wear. And fortunately, over the last 15 years, we've gotten better devices that are much more flexible, allow people to have multiple programs and adjust the sound profile as well as the volume to help them in different situations. And of course, this is advantageous because they can wear them consistently. And so I really think about sound therapy as consistent daily support. It's something that they can use regardless of the situation that they're in, that they can use them at school, they can use them at work, they can use them at home, and it is something that allows them to be in the situations, performing their daily functions without as much disturbance. And so I think from that perspective, that is a unique a unique tool that audiologists can provide.
Okay, thank you. There are some other specific questions about sound, which I'll come back to, and blocking sound. I'll come back to that. But let's go over to Caroline for a moment. Many of the questions have to do with what do you think can help besides avoiding or masking sounds? What are some specific coping strategies to deal with negative emotions that arise? And there were several other, what do I do about keyboard typing? What do I do with specific kinds of music that get through to me that are troublesome to me? So what might you have to say about that from the therapy side?
Yeah, it's a big question. And I find that, people we don't all have the same trigger sounds. And so it really depends. And it's kind of hard to give a big answer to that. But I guess I'll start with, beyond avoidance. So I call it exposure and response prevention. When we start thinking about, what are the environments, the who, what, when, where, that we can typically expect a trigger sound to enter into our awareness. And I'm of the mind that it's not necessarily a negative thing to be thinking ahead about that and planning for it with tools, with, either sound tools or like Lisa was talking about, having something that's really not just going to block all sound completely, but sort of neutralize sound. So that's an important piece of it. And something that I work on with clients a lot is actually moving away from using that word of avoidance, because there can be sort of a negative connotation with it, and really thinking about exposure prevention, thinking about it more in the prevention way of thinking of things. So, and that's not bad. That's a responsible thing that we can do to plan ahead and take care of ourselves. And beyond that, though, there are so many other things that we can do to address the whole self. There's misophonia, and then we have like this whole other life and other things happening, right? And there might be some anxiety or depression or some other mental health issue that can be underlying or sort of like exacerbate the symptoms of misophonia, especially, if there are hormonal changes happening. That's really commonly a common one. Can be easier to sort of see, like if a woman is, during her cycle, certain periods of her cycle, trigger sounds, the responses will be a lot bigger and harder to manage. So But just getting back to like addressing the whole self and our nervous system and our overall mental health. It's so important to create moments throughout our days, people with misophonia, where we're not triggered, where we can be in a more of a rest and digest state. And I talk about the ventral vagal state, that's the parasympathetic nervous system. So we have the autonomic nervous system. We have a sympathetic state, which is, you might know, is like the fight or flight state. Like when we are in a trigger response, we're in that fight or flight. That is a sympathetic nervous system really kicking into gear. You can feel it in your body. The heart is racing. There are a lot of physiological correlates to that experience. And then conversely, when we're resting, when we're not triggered and we're able to really relax, which can be really hard for someone with misophonia to do because there's so much hypervigilance around a sound potentially entering their environment, even if there's no sound happening in the moment. So nervous system regulation is a really big focus in my practice and my work with people with misophonia, to really support the nervous system so that it can actually experience homeostasis and regulation, because it's less common for us to be able to be in that state, just given the nature of the hypervigilance, again, with that comes along with misophonia. So, and there are plenty of tools to support parasympathetic nervous system health. I'm happy to speak about some of those. If you'd like, I'm happy to share some of the specific tools that I help people integrate into their daily lives. Maybe you give a nod, or Jaelline, if you think that would be helpful to do right now, or we can pause.
I think we can come back if we have time, because we have, but right now, so many questions to address that I think we're going to do a broad sweep today. And if we have a little time, we can get into more specifics after a while. So let's pause on that piece of it. Okay.
Sounds good.
I want to jump in on one thing that Caroline said, just to clarify, at least from my perspective as a therapist. I see a lot of people who have, before they came to me, they went to someone who I think misinterprets misophonia as a phobia. And one of the treatments for a phobia, like you're afraid of spiders, so we're going to show you a picture of a spider, and now we're going to show you a picture closer, a bigger picture, and then we're going to show you a real spider. And it's a little bit of exposure until you get used to it and so forth. Exposure therapy in treating misophonia often backfires. Putting someone in the center of a circle and having their family sit around and eat something that's very disruptive to them is more like torture than it is helpful. So if exposure therapy is proposed to someone as a treatment, you might want to know exactly what is it they have in mind, because I think the way that Caroline is talking about it is different from that extreme. So, okay, moving on, with going back to the sound things for a minute, what about using earplugs? And there are various types of earplugs that are on the market, popular now. Couple of questions about that. What do you think about them? Are they helpful? And are there downsides to earplugs or AirPods?
Yeah, I alluded to that just a second ago. We actually gave a presentation at the Misophonia Awareness. My student, Amy Hedrick, who is a student at NC State University, did a research project for her school looking at different types of earplugs and people's perceptions of them. And so that prompted us to do a little bit more investigation as to how earplugs affect people's perceptions, especially with regard to triggers or to speech understanding. So one of the downsides of earplugs is that when you're wearing them, you might not be able to hear speech or be able to communicate as well. And so that can be a barrier to using them in certain situations. And so depending on the type of earplug, I think it's super important for people to know that not all earplugs are created equal, right? So there are different types of earplugs, and there are some that are marketed specifically to people with misophonia. So you've probably seen ads for the Loop or for the Flare. And those are two different types of earplugs. The Flare is actually not even an earplug. It doesn't have a noise reduction rating because it has a hole that goes all the way through it. So its goal really is just to change sort of the acoustics, the way that the sound enters the ear, and take the edge off some of the higher pitches. Now it's true, and I think it's very important that, again, that people understand triggers are all different pitches. So some people talked about, the low bass sounds. Other people talk about higher pitch sounds that are often associated with certain activities. I'm mentioning triggers specifically, but it is true that people often are bothered by one or the other, or both. And so it is important that when you're thinking about trying to buffer a sound or avoid a sound in terms of not hearing it as much, that the device that you're using is going to matter. So the Flare is going to provide a small amount of attenuation for the highest pitches and have the least amount of impact on speech understanding. As you introduce more and more occluding types of earplugs, the Loop, for example, is going to have more attenuation in the mid to high frequencies, whereas foam earplugs are going to attenuate more of the speech frequencies and make it even harder to hear and understand. So again, depending on your situation and the particular triggers that you're wanting to avoid, and the need to communicate, you may find that you may use different types of earplugs for different situations. Of course, the downside of wearing earplugs on a consistent basis is that you can give yourself increased sensitivity by of the auditory deprivation that can cause. So as audiologists, we do get concerned when we hear about people wearing earplugs a lot, routinely, in all situations, because we do worry that that may increase your sensitivity to sound over time. So I'm not saying all earplugs are bad. Yes, Marsha, just let me finish my statement. We're not saying that all earplugs are bad, and we're not saying that there are not certain situations that they may be appropriate, but we do like to caution people about wearing earplugs on the regular or in all situations. Marsha.
Oh, thank you, Lisa. I love your perspective. I love your study. I just can't stop from telling everybody we just got an article at the Misophonia Association from a project they're doing up in Seattle, and they have developed a headset with artificial intelligence that can purposefully detect, understand, recognize, and cut out particular sounds. Now, I don't know if I can believe this or not. Maybe it was just a fantasy. I did put it on our Facebook site. Everybody should try to read that. This could be very exciting if you're a person that has an aversion to a very specific sound, and you can instruct your headset. You don't want to hear that particular noise, like a refrigerator or something. We don't like to mention triggers. But anyway, I just couldn't resist the opportunity to say, research is helping us.
Yes.
So
No,
we can get
that's very
excited about
interesting.
that area.
Very interesting. Thank you for sharing. And that's a great point, is some people use headphones, noise canceling headphones, for example, in lieu of earplugs. And some people, my daughter included, who has some sound sensitivity, find that beneficial. The downside of wearing headphones, again, is that it can violate a social convention, right? So sometimes you can't wear earplugs at work, or headphones at work. You can't wear headphones at school. So that is the downside of that. And then I think there was a question about any potential harm that maybe using AirPods with music could cause, and that is another concern that we have, that, I have actually seen people give themselves hearing loss by playing music so loudly to drown out trigger sounds that they end up with some loss of hearing, and that can be permanent and can sometimes be associated with tinnitus, which is like ringing in the ears, and that's a whole nother problem. So we do want to make sure that people are utilizing devices, whatever they may be, in an optimal way. And I think that is one way an audiologist might advise you as to, what are you using, when are you using it, how are you using it, and at what volume. So we have ways to measure objectively the output of any devices that you're using, and that's one advantage of the sound therapy devices that we fit, is we make sure that they're safe even at maximum levels, because we don't want people to cause any harm to their auditory system in the efforts of blocking sounds. So hope that's helpful.
Great. Okay. And thank you, Marsha, for jumping in on that. There are a number of questions regarding what are known as co-occurring disorders, or comorbidities is one of the other words that's used to describe it. What else might be going on with someone who has misophonia? There are several questions that have to do with the autism spectrum, whether people with an ASD diagnosis have misophonia, or whether it's part of that diagnosis, and what do you do to manage that? There are many questions about whether it's related to sensory processing, attention deficit, that kind of thing, neurodiversity, that sort of thing, generalized anxiety, OCD, all those kinds of things. So probably Caroline has seen people who have co-occurring conditions. Do you want to address any of that?
Yeah, sure. I can address it just from the perspective, like with some anecdotal data, just from my own practice. And I have not, in my experience, and again, like this is not, my experience is not like the end all. This is just from the folks that I've worked with. I haven't seen a lot of co-occurring like autism spectrum folks. That just might be, there could be a number of reasons for that, but that's not, there's not one particular comorbidity that I've found across the board is shared among all people with misophonia, except for possibly anxiety. And that is really understandable because, and it's also kind of like a chicken or the egg thing, does having misophonia cause anxiety? Does having anxiety, did that trigger misophonia starting? We don't know, we don't know that necessarily, but there does tend to be the experience of anxiety present for folks who have misophonia. And there can also be depression as well, which is also understandable given that it's a really difficult thing to manage, to have. And so yeah, but as far, I know that people come to me a lot of the time asking, like, is this a kind of OCD? Is this related to ADHD, PTSD, right? Like triggers, being triggered by something specific. There's a lot of, there's some crossover, but in terms of symptomology, however, I haven't found any clear evidence that would suggest any kind of causative relationship between misophonia and another condition.
Lisa.
Having seen kids, I might be seeing more patients that would fall on the spectrum, and my daughter included. So I do have some personal experience with that as well. I would say a good percentage of people that I see have other comorbid diagnoses, and I always think it's, it's always a question is, well, is that just because of the professional that they saw before they got to me? They didn't know what to call this, so they called it OCD, or they called it an attentional deficit disorder because they're distracted by sounds. Sometimes, of course, the two can co-occur. I do think that there is a certain percentage of people on the spectrum who do have sensory sensitivities, and I do think that sometimes that does manifest as a misophonic reaction, and it also oftentimes manifests in other modalities too. So one of the questionnaires that we give folks when they come in is a central sensitization inventory. And I often will look at the score on that questionnaire to guide me into whether or not, this person is having a more extreme central sensitization beyond just what's in the auditory, modality. And sometimes that may suggest that additional intervention is needed. For example, one of the interventions that we offer, and I believe Caroline may be soon offering this as well, is a safe and sound protocol through the Unite organization, and that is a sound therapy program that was really designed to help people with on the auditory spectrum or the autism spectrum. So sometimes that might lead me to believe that might be a place to start with those folks. But I do think that we do tend to see people with other types of sensitivities, and I'm seeing people even with, not disorders, but people who have certain profiles that you might consider unique, highly sensitive person profile, for example, and so that can sometimes make them more sensitive to environmental stimuli, and make them much more empathic and observant in terms of their environment. So I think trying to better understand, it's great questions, because we definitely are trying to best understand how at least some people may develop misophonia, or what other conditions might be associated, but I don't think that there's any clear-cut evidence at this point that one thing causes another.
I think possibly one of the reasons that people on the spectrum might not show up as often for specifically to deal with misophonia is that there are a number of services out there available for people on the spectrum. So they may have other places to go to get the help that they need with a variety of sensory processing disorders, and they don't necessarily show up on our doorsteps. So that is part of I think of that piece. On the lines of what else it could be or how else it shows up, and as Lisa said, maybe they saw somebody who gave them a diagnosis. As you are all undoubtedly aware, there's no such diagnosis as misophonia yet. It isn't in the code books. I'm fairly certain that's because there isn't enough research yet to say, well, this is what it is. It's a standalone disorder. It doesn't belong anywhere other than its own little box. Or it's a type of something else. It's a type of anxiety disorder. It's a type of OCD or PTSD or whatever. So until there's more definitive research, it doesn't have a diagnostic code, which means this leads to another set of questions that we received. How is it diagnosed? And how do you get support for something that doesn't have a diagnosis? So one of the things that happens is that we have to, those of us who are in the world where we have to give diagnoses, there is an audiology diagnosis code. It starts with an H, and that fits into that world. And let me see, H93.2, which is
abnormal auditory perception.
Correct. Yeah.
Welcome. We have the first code, but
Yeah.
there'll be new codes. You don't have to worry about that because you're mental health therapists will give you like highly anxiety disorder, or they have a lot of other terms they can use for this. They can't do misophonia yet, but they know how to manipulate that, I'm pretty sure.
Right. So I mean, most frequently end up using, thank you, Marsha. I most frequently use something like a generalized anxiety disorder, which was one of the things that someone asked. That can apply to almost anything. You know, as was pointed out earlier, by I think Caroline said, if you were anxious to begin with, maybe that led to your having some reactivity to certain sounds. But in any case, once you have misophonia as a reactivity, you're anxious because you're always looking over your shoulder or wherever it is you are for the next time that sound is going to show up. So you have a lot of anticipatory anxiety. So a generalized anxiety disorder is a legitimate diagnosis to give to somebody in the absence of a code for misophonia. How do you diagnose it for sure is one of the questions. Well, in this field, there's nothing for sure. So you kind of have to lean toward what shows up most frequently with that individual person. Maybe it's more OCD-ish. Maybe it's more PTSD have related to some trauma. It depends on the individual. Another question, which I think comes up often, how do you know it's misophonia when it's a teenager? How do you know that they're not just being a teenager? Especially true for girls, because girls have a lot of hormonal things going on, and it happens that misophonia often shows up around puberty. Does that mean hormonal changes are the cause? We can't say that. Maybe it contributes, but that doesn't explain boys, and that doesn't explain people who develop misophonia much earlier than puberty or in their adulthood or something. So we can't say for sure that it's hormonal. What do you do when you have a teenager and you're trying to help the family figure out, is this misophonia or is this just a teenager full of angst?
I can jump in for that one. Yeah, it's tricky. I think it's really important to work with a therapist on that. And I'm very lucky in a way, to have misophonia because I can really understand and help people differentiate between the experience of being bothered by like something that's annoying and irksome and having a misophonic response to a trigger. And there are a number of scales and measurements out there right now that are being developed and have been developed for us to rate and to get close to diagnosing misophonia. There is not, like Jaelline said, there's not a code in the DSM currently for misophonia. There are not specific diagnostic criteria yet, but we have a lot of pretty good measures that we can use in the meantime. And, asking questions like how much of your time is occupied by misophonic sounds or thinking about sounds or a trigger sound. How much do these sounds interfere with your daily life? I'm just looking at a scale that I use personally in my practice right now. How much distress do the sounds cause you? What level of stimulus discrimination is involved in your reaction to a trigger sound? So like, does a sound that's being made by a certain person bother you more than when another person makes it? Things like that. And it's, by asking these questions, it becomes to me clear pretty quickly when it's misophonia versus something else. There is like I spoke about earlier, that hypervigilance that comes along with this, where it's like, it's just kind of ever present. And then also the quality of the response, the quality of the reaction is pretty darn intense. It's not just being annoyed by something or a sensory dislike. It's deeper than that. And so I would say if you can find a therapist that specializes in misophonia, or at least is familiar, that is what I would recommend. I'm here. You feel free to reach out to me if that's something that I can help with in any way. I'm really happy to do that. But yeah, I would say before writing it off as something else potentially, it's definitely worthwhile to thoroughly investigate, is this misophonia, and just get clear on that. In order to move forward with an appropriate solution, it's important to get that clarity.
Along those lines, the idea that there are certain sounds that are different when they come from certain sources. It isn't the sound by itself, which is one of the things that makes it so complicated. It is not just the sound of whatever. We don't name triggers as much as we can because people with misophonia have this kind of interesting habit of hearing about a new sound and they say, oh, does that bother me? I hadn't noticed before. And then it starts bothering them. So we don't name sounds as much as we possibly can avoid doing so. But it does seem to be a common phenomenon that a certain sound is more troublesome when it comes from that person than when it comes from some other person or some other source. And there are a lot of ideas about why that is. I have some answers to that from the psychology side of it, but I have heard, and maybe Lisa can address this, the proposition that there are some audiological explanations for that have to do with the different intonations or wave patterns, or whether it's higher or deeper or whatever else it might be, that could explain why it is harder to hear, for somebody to hear that sound from that person. Oh, and Marsha has something to say.
Well, she's getting into Marsha Johnson's sound fingerprint theory. I've written a few articles on this where I hypothesize that if your mother is doing a particular action, the sounds, even though the main item might be the same exact thing, the sounds out of her resonant mouth and nasal capacity there, these chasms, these caves, and her teeth and all these other things I'm not going to go into, creates a unique, what I call a sound fingerprint. And your brain latches onto that when you have misophonia, just the way that if I smell a rose, it smells this way. If I'm eating chocolate, I know it's chocolate. Your brain only interprets electrical patterns. And my theory is that these unique patterns get associated because they are unique, and then your brain hates them viciously. It's like me seeing a spider crawling on my arm. I would be flipping out. So this is my theory, which Lisa doesn't know about yet, but now that I have once again interjected, I'm hiding back. I'm supposed to be tech woman.
Yeah, that's very interesting, the idea of a sound fingerprint. I typically think I've got a couple of thoughts, I guess, about this. I don't know specifically about certain resonances, or I do know that for whatever reason, certain people can be more triggering than others. And I do think it tends to be people that you're more familiar with, people that are your safe people that are not going to abandon you. And a lot of times people spend their entire day suppressing the reaction that they're having to misophonia sounds, and then they get home in their safe space and let it all out, right, on the people who are closest to them. And that really stinks for everyone, I know, and it harms relationships. But I do think that, I've even had people tell me, well, it bothers me more when I know they know that this sound bothers me, right? And who's supposed to protect me the most but my mother, my father, my brother, my sister, right? And so sometimes I do think it has to do with that, right? Like, even though they know that it's not intentional, it's because it's a person that's close to them that they have a deep relationship with, that for whatever reason that seems like more of a personal a personal attack. I do know from a sound perspective, and this is evolutionary, that really deep sounds and really high-pitched sounds are threatening to the human beings, right? And that just comes back to the days when, you know, we were hunter-gatherers, and the lion off in the distance, you know, roared, and the sound traveled across a distance, and that low, deep sound was threatening to us. Similarly, if we hear a twig breaking in the bushes right before the lion eats us, you know, that high-pitched sound is threatening to us. So I do think that our auditory systems are primed in a way to be really bothered by really deep bass sounds as well as really high pitched sounds. And a lot of the triggers that people describe to me fall in one of those two categories. Speech, on the other hand, is right in the middle, right? Like speech has a frequency response of somewhere between 250 and 8,000 hertz. And oftentimes what I find when I measure hearing in people with misophonia, and I do think it's very interesting that we go ahead and measure out beyond where we typically would measure. We would normally stop measuring at 8,000 hertz, and we go ahead and measure on out to 16,000 hertz, because what I find in a lot of people with misophonia, sorry, my watch is talking to me, is that they have really exceptional hearing out in those extended high frequencies. And it almost creates sort of, I apologize for using my hands, but sort of an upward sloping configuration to their hearing, where those higher pitches are almost acoustically highlighted for those people. And so they sound louder to them than they might sound to someone else. That doesn't explain the reaction, but it might explain why those sounds stand out a bit more to those people, why they're harder for them to ignore. So, like, once again, when we get into sound therapy, one of our objectives is to try to help balance that out for people, so that the higher pitch sounds aren't as it's like having, you know, the treble turned all the way up on your stereo, where it sounds really sharp and harsh. It's very unpleasant for people. We try to balance that out and smooth out the response. That's what someone described to me who had misophonia her whole life, is it just takes the edges off. It just smooths out the response so that it's easier to listen to. So I think that's one advantage of sound therapy, is we're not taking away all sound, and we're not giving the impression necessarily that these sounds are inherently bad. Like Dr. Jaffe said, these are not, you know, inherently bad sounds. It's how our body is responding to the sound that we really are needing to work on, teaching our brain that these aren't sounds that are threats, and that they're not sounds that deserve the attention that they're currently getting.
So thank you. There are a number of questions that have to do with how do you help a family member who has misophonia? How do you start getting help? Where do we start finding treatment or relief for a child? Is there any treatment? What can we do to help our child manage this? What are some proven treatments for misophonia? What can family members do to help our child's symptoms lessen in severity? What should be my focus as my daughter transitions from teenage to adult living with misophonia? I'm looking for any kind of treatment that is proven effective or helpful to reduce or eliminate symptoms. Are there any treatments available? So in the general category of how do we treat misophonia, you've already heard a number of things that audiology can do, and you've heard somewhat of what psychology can do. So let's dig into this a little more. How do you find resources, and what might be a way to go about getting some help? Want to jump in on that, maybe, Caroline?
Yeah, sure. I wish there were more resources, honestly, that, you know, that more people specialized in working with folks with misophonia. I will say that, you know, even a consultation for a family, especially like a short-term sort of coaching session periods can be really helpful for families to identify environments, the who, what, when, where that are most triggering and troublesome, and problem solve. Just implement strategies around how to manage those particularly difficult situations. And that's something that I do with people out of state on a regular basis. I'm licensed in New York, but I offer that kind of coaching a service to folks to do that short term. Let's make this manageable kind of treatment. And that can be really, really helpful. And, especially if the family is also open to working with, like, taking an interdisciplinary approach, also work with an audiologist and work with a mental health practitioner in their state and in their area that can look at things like medications. So I'm going to just speak sort of broadly on that. And this is not a recommendation. I'm not giving medical advice, but just sort of like anecdotally, just from the people that I've worked with and what I've witnessed, some medications can be helpful to treat some of the underlying anxiety that might be present for a person that tends to worsen the misophonia response. I've had clients take SSRIs or try SSRIs and experience some really good results with that make them feel a little bit less vulnerable, a little bit less like an open wound all the time. And that's not always the case, especially with SSRIs. I found that it really varies person to person. So just keep that in mind. There's also a study, and I think the Mount Sinai in New York is maybe doing this right now, a study on propranolol beta blockers for people with misophonia. It's something to look into. There's a journal article on my website, among like many other journal articles that I have listed on my website, that can be helpful to read through and understand kind of what's going on in research now and what we're finding, what we know so far. So that's something to look into. And if there are any other co-occurring conditions, just getting those managed so that, life is just a little bit easier to manage. That's definitely a recommendation. If you can find someone who works in acceptance and commitment therapy, I think that that's a really helpful modality, because a lot of people that come to me come and saying, I hate this, I hate that I have this, and I want a cure. I'm not willing to accept it. And while that's totally understandable, because it's a really, really difficult thing to have and to deal with having forever, acceptance, in my view, is a really important first step in the process of healing. Accepting the fact that, hey, I have this condition, misophonia. It is a disability, right? Essentially, I'm not choosing this. I didn't choose this for myself. I would never choose this. I've never spoken to anyone with misophonia who's like, yeah, I would choose this. This is how I want my life to be. It's not at all. They hate it and want to get rid of it, and understandably so. So just kind of coming to terms with, like, hey, I have this chronic thing. There's no cure for it yet, unfortunately. So what do we do about it? How do we live with it? And how do we live well with it? And that's what therapy can really help with. And it's a combination of like the different therapeutic modalities, but also just being willing to be flexible, to make changes, not only the person with misophonia, but their family members, their loved ones. So important to get those folks involved and educated. There are a lot of articles out there. If you just Google misophonia, you can find reputable sources writing about misophonia and saying, hey, this is the thing and this is what it's like. And that can be really helpful to print those out and hand them to your loved one, your parent, your sibling, your partner, your friend, whatever, whoever it may be, and just help them to understand that this is a real thing. And that the responsibility, we're all at the end of the day responsible for ourselves, right? We accept the things that we can't change and we change what we can. And what we can change is how we communicate our needs, what the choices that we make in our lives. I'm going to be willingly put myself in this situation, or I'm going to take myself out of this situation. I'm going to agree to do something, or I'm not going to agree to do something. That's the power that we have. So really focusing on that can be actually really powerful. But I think what's the most important thing, again, I'll just say it a million times, is the acceptance piece, and then just being willing to be flexible and making changes as needed. Because life is different for someone with misophonia, and you're going to have to do things a little bit differently. And while that's not ideal, it's okay. It's okay, you know.
I want to tag on to that. I really appreciate what you're saying in a lot of ways. Caroline, the acceptance idea, and did I sign up for this? Did I ask to have this problem? That's huge. There's another piece that I don't start with this when I'm working with people. I don't start with this perspective, but eventually we get around to a place of, is this something that you would trade for something else if you could, which of course you can't, but if you could, do you know somebody that has something else that you would not want to have to deal with? And pretty much anybody can come up with that. Well, yeah, I know someone who has such and such, and they'd probably rather have misophonia than that thing they've got. And I don't want that thing that they've got either. So it kind of puts it in perspective as it's one of many, many things that we human beings sometimes have to deal with. We have things that happen, and we have conditions that show up, and pretty much everybody ends up with something that they have to deal with. And we didn't ask for it. We didn't sign up for it, but we have to learn how to deal with it anyway. And if we can change it or fix it or make it be different, that's lovely. And if we can't, what are we going to do? Be mad all the time, which is what some people do. They're just angry all the time about this thing that has been thrown at them. And that isn't very helpful as far as functioning on a day-to-day basis. I think it's fine to be mad and then get over being mad, get past that, and get to the place where you can say, okay, now how do I live with this thing that at least for now isn't going away? Will it ever go away? I don't know. But one thing that we have noticed, I don't know if you have, I have noticed, is that when people get to the place where they can be more peaceful and less upset about it, it actually feels different. It isn't as intense because your attention isn't focused on how awful things are all the time. Your attention can be put on, getting on with life and finding things you like to do and being a part of the world and, being a part of your family and your school and your job and those sort of things. Those things become more likely when your full attention isn't caught up in, oh my God, this is awful and I can't stand it and it shouldn't have happened and it's going to just drive me nuts for the rest of my life. If you get to the place where you can kind of figure out how to accept it, doesn't mean you like it. Acceptance doesn't mean you like it. But you just kind of recognize this is what it is right now anyway, and go from there. One of the things you mentioned was the medication. We don't prescribe medications. The therapists don't prescribe medications unless they're medical doctors. There is one medical doctor that's involved with the Misophonia Association who's done some really interesting presentations and is doing some exploratory work, which may be the article that Caroline was referring to with propranolol. It's kind of a thing discovered. It's one of those things where it's an off-label purpose to try to see if it'll help. I happen to have one person that I'm working with of hundreds and hundreds of people. I've got one guy I'm working with who got his primary doctor to write him a prescription for propranolol, and he's actually been finding it very helpful. Now, does that mean it's the solution to this problem? Who knows? Probably not the solution. Maybe it'll help some people. Certainly not going to be something you're going to prescribe for children, I don't think. So there have to be other things to do in addition to that. But Jaden Webb, that's the psychiatrist who's working with misophonia, he's in Denver. he's on our provider list, as well as I think all of us on the screen are on the provider list. It's on the Misophonia Association website. There aren't enough of us. That's true for sure. There aren't enough audiologists who know about or help with misophonia, which always strikes me as odd. Like, why not? And there certainly are not enough therapists. So those are areas where we really need to expand the availability of resources. I'm working on a training program for therapists to get more of them involved, and I think it's really tough to have the limited number of resources that we have available. Hello, Marsha.
I'm back. Listening to you guys is a lot of fun for me because 27 years ago, there were no articles on misophonia whatsoever. The word didn't exist, of course, but even the condition, there were literally no articles. One hysterical woman from Australia they were all diagnosed with psychological conditions because this was considered a psychological abnormality. No one ever thought to look at it too closely. People were scattered all over the world. And even today, when you talk about why don't more audiologists know? Well, even myself, 27 years into this, I'm not convinced this belongs to audiology.
Mhm.
I am not convinced at all. As a matter of fact, remember, I started collecting these people and I got up to 5,000 people in a Yahoo support group who had identical conditions and symptoms, and they were like triplets. And I was like, what is this? How can this be? But we have so many other avenues of effect. It's visual, it's tactile, it's memory based, it's ideation, I don't know the term. There's a big war going on in our field, this little condition, between psychology and scientific thinkers, more in the field of scientific measurement. And that is why we don't have diagnostic code, because this keeps going back and forth like a tennis ball out of game. And who owns it? And I keep asking people, I'm going to ask all of you today, why don't we just have a combined category of diagnostic conditions? I'm sorry. There's things that affect your body and your neural functioning, and they affect your soul and your heart and your feelings. Why do we have to split people in half? It doesn't make sense to me. And these things I love what you're saying. You're doing your best, but why aren't there more people? Yeah, that's a great question. And I'll tell you, we have a lot more people now when there was just me. The first convention, it was like, Marsha, get the experts. I'm like, where are they? No, wait, I'm it. And I only know X amount. But Jaelline came along and we started working, and we have done such great work. Look at you two. I'm very happy. I'm going away now.
I will say that I train doctoral students, and so that is part of my job. And so students from across the United States come and train with us, and some of them have gone off and continue to do some of the work that they've learned with me, and some of them unfortunately can't because of the clinical um, restrictions wherever they're working. I mean, this does require time. Working with this population and working with people with misophonia need and deserve time, and so I do think that is one of the things that just sort of the clinical model under which a lot of clinicians are forced to work, and trying to get people in and out the door, and sometimes that does work against us, unfortunately. But I do hear what everyone is saying and agree that it's really more about managing misophonia more so than curing or treating it. And I do think I look at it at sort of a top down and bottom up type of approach. And I do think that's what is so great about a team approach, is that someone like Caroline can really work with people on their belief systems and their coping strategies, and how they live with misophonia in their daily life. as an audiologist, I feel like we can help with sound awareness and help people be able to function a little bit easier, not have to work as hard, not feel like as isolated. And so the two together do work really well. And so I definitely agree with everyone that, I'm one of those people, I don't care what you call it, right? But how can we help? And so if there's something that we can do to improve quality of life and just make living with misophonia a little bit easier, then that's something that I think is worthwhile.
Okay, let's, oops. Yeah, oh, okay. Let's look at one of the other major categories of questions that were raised, and that has to do with, we've already alluded to it, but with some more depth, the effect that this has on families. So as Marsha said a long time ago, this is not an individual's problem. It becomes a family problem. It almost always develops initially in the family. It almost every email I get from somebody saying help starts out with, we can't sit at the dinner table anymore. It almost always starts in that sort of a way, and it affects everybody in the family. So this is one of the places where I want more therapists involved, because therapists, at least presumably, are trained to work with family relationships and interactions and the way that things are connected, and they're not individual. It's not like go see a psychoanalyst for a period of 100 years and work on your own inner world. You live in a family and everybody in the family is affected. So here are some of the questions that were posed, and let's see if we can address these. My 14-year-old daughter can't stand it when I eat or drink, especially in the car. Should I try not to eat or drink around her? So it's a big question called accommodation. What do we do to accommodate? What's reasonable? And often parents don't have the same opinion about that. One person, kind of more typically mom, says, what do we do to make life easier? And often dad says, the world isn't going to make life easier. She needs to learn how to manage this. So we shouldn't pander her or, pamper her or whatever. So should I not eat or drink in the car? Do you have any tips for dealing with siblings? Well, let's start with that one. Let's start with the being in the car. Being in the car is often a problem. You can't escape the car. If you're the kid in the car, you can't leave the room. So you're trapped. And that adds to the intensity. So what do you think, you two people who've worked with people with misophonia, should the driver or other people in the car not eat or drink if that's a problem?
Yeah, I can jump in first. Yeah, well, so from my perspective, I think that is an okay and reasonable request and accommodation. It is not going to cause the driver, or I'm assuming she's driving the car, any harm to not eat or drink in the car, I'm assuming. So it's, I think, important to look at these specific situations and look at potential harm and weigh things out, right? So like asking someone not to breathe is different than asking them not to snack when they're in the car. And I think personally, I think that that's a totally reasonable request and something that you could do, I'm assuming, and that would probably really, really help your daughter. And I think any opportunity that we can make those kinds of changes and it's doable, I say go for it. Absolutely. I'm not of the mind that, that whatever kills you makes you stronger with misophonia, or whatever doesn't kill you makes you stronger with misophonia. That's not been my experience personally, and it hasn't helped other people that I've worked with that have either had parents that have taken that approach or have tried to take it themselves by pushing through. So yeah, I say absolutely accommodate. Part of the acceptance piece that I was talking about earlier, and I want to clarify this too, accepting something doesn't mean choosing it.
Mhm.
It does not mean choosing it. It does not mean liking it. It just means acknowledging the reality of what is. That's it. And not fighting reality. So not only is it helpful for the person with misophonia to find acceptance, but for their loved ones. They have to find acceptance too before they can be comfortable and willingly make these kinds of accommodations. So if we accept, say Mary, Mary has misophonia, right? It's really triggering to her when people eat around her. Okay, we know that. There's no arguing that. There's no value judgment, right or wrong around that. It just is. So what can we do to support her? And moving forward from there, it's pretty simple, I think, in that situation anyway. It can get pretty complex. But I say it's okay to accommodate. And then as for the fear of sheltering a child so that they're not able to kind of blossom and become an adult and take care of themselves as needed, it's important to teach advocacy, self-advocacy skills, and communication. Communication in terms of the family system here, which I mean, that it is such an inherent piece of this. Misophonia it's a family, it's a family affair. And because other people are so inherently involved, right? And in it. So we have to sort of take that a systems approach and teach the child, if we're talking about a child with misophonia now, how to communicate their needs, how to get comfortable saying, I have this thing. Here's how these sounds affect me. These are the sounds that affect me. Getting clear on, on what that is, and get comfortable having needs and expressing needs and asking for help. That's actually a strength, to be able to say, hey, I know myself, here's my situation. I'm coming to you for help with this. And so yeah, so that piece, the acceptance, and then the teaching advocacy skills, so that person can grow into an adult that is able to take care of themselves and their needs and communicate their needs and have them taken care of by others as needed. Does that sort of?
Yeah, Lisa, you have some thoughts on that?
Yeah, I've heard everything across the spectrum, I think, from I will not accommodate to a parent who sits in her own room and eats her dinner because away from the family because she doesn't want to trigger her child. So, I think that accommodations are, that are reasonable or appropriate. I think it's much easier if everyone is doing their part and utilizing the tools that are available to them. So that's one thing that we talk about is, what can you do? You can't change people, places, and things. What can you do to help yourself be more comfortable or less bothered by these sounds? And so whether that's utilizing sound therapy, whether or earplugs in that situation when a situation you can't get away, whether that is using some breathing techniques to help yourself address the physiological discomfort that you're experiencing in that moment. So I do think that accommodations, there's definitely a room for accommodations, and especially with our loved ones, we want our loved ones to be comfortable. But I think it's also important that the person with misophonia is doing their part too, to see how can they, address the situation too, so that everyone can be comfortable.
Okay. Let's get into a few more. We have about 10 more minutes, and there are some more questions about family relationships. What on earth do I do as a parent being targeted and rejected and honestly feeling abused at this point? Because absolutely everything I do is a problem for my kid. I have a response to that. Your child is probably not doing this on purpose. They're not trying to have reactions to the things that you as a parent happen to be the one who does it. In a way, it's a compliment to say to you, it's a weird backhanded compliment to say, I feel safe yelling at you and letting down my guard with you at home because I can't do that at school. I have to hold it together at school. If I yelled at my friends, they wouldn't be my friends anymore. If I come home and I yell at my family, they're probably not going to kick me out of their lives. They might feel like it, but they're probably not going to. So I think if you can remember as a parent that they're not doing this on purpose to get to you. They're having a neurological knee-jerk reaction to those sounds. If you imagine that the doctor hits your knee and your foot pops up, it's like that. They're just having a reaction. It is not volitional. Now, I think kids do need to learn how to modify their reaction, and maybe after they've reacted to calm themselves down more quickly and be able to apologize for blowing up for something, because they almost always recognize after the fact that their reaction was excessive. And many times, most times probably, they do apologize. So I think that being the parent, you have the difficult challenge that parents have in general, which is we have to be the bigger person. We have to just kind of realize that our kids are not going to like everything we do, and we're going to do our best not to react back at them, because that doesn't help any. So of course you may be upset, but if you feel like you're being rejected and abused, I think you maybe could talk to a therapist to see how you can sort that part out for yourself, because your child isn't probably intending to reject or abuse you. They're just having a misophonia reaction. So you kind of have to be the bigger person, I think, in that situation. There are a couple of other questions here that have
Can I jump on that, Jaelline, really quick? I just want to add, just during that, I've heard that from family members also, is like, I feel like I'm being abused. This is like, so that's not an uncommon sort of feeling, especially before that person really starts to understand misophonia and exactly what their loved one is going through in that moment. But I just want to mention the attitudes that can change and are very, very changeable from between like the attitudes and the things that are said during an episode, during a misophonic reaction, and the rest of the time. So when someone with misophonia is in the height of their misophonic, I'll say misophonic, I don't know if that's a real word, but I use it all the time because it kind of works. When they're in the height of that misophonic response, their attitudes about the person making that noise are very different than how they feel about that person the rest of the time. And that is really normal. I would say that most of actually all of the clients that I work with, the way that they feel in those moments, it to them feels like a deviation from their actual character. So when they're in the height of a trigger response and they're hating the person, feeling rage and disgust and all of those really intense feelings towards that person, they report that that is not how they actually really feel about that person. There is something that is happening in the nervous system, that fight or flight response, that is completely changing the autonomic state that the person is in. And so I would say just try to remember that, you know, people with misophonia report that when those feelings that they feel at the height of a trigger are not how they actually feel most of the time. And maybe that could be helpful for people who are living with someone with misophonia who feels like a target of that person's anger and disgust in those moments. I just wanted to mention that. And I'm hoping that's helpful.
Agree. Thank you. Let's get a couple more of these family relationship questions in if we can before we have to wrap up. This has to do with siblings. Do you have any tips for dealing with siblings? One of them hums and sings to soothe themselves. The other ones have trouble with those sounds, apparently. What tips do you have? We allowed our 17-year-old to isolate herself from her 12-year-old brother for 4 years. How do we end the isolation? So what are your thoughts about sibling relationships? And I will toss one thing out here before sending it over to you two. It's hard having any kind of special needs child in a family. They end up needing attention, and that means other children in the family end up feeling deprived of attention. So one solution to that is to make sure you spend time with all of your kids, even if it's 5 minutes where it's exclusively their time, and you don't let the other child's needs interrupt for a little while, so that each child knows that they have mom or dad's attention, exclusively, at least sometimes. So that would be one way to approach it. Other thoughts?
I hate to sound like a broken record, but I will say that I have had sibling patients who have been triggered primarily by their sibling, where the parents were considering even living apart in order to help both children be comfortable. And the use of sound therapy devices at home was a game changer for them. That did allow those siblings to be around each other more comfortably without that being a divisive thing. So I do think whether it's sound therapy devices, whether it's headphones, whether it's something that you can tailor specifically for that person. And again, I just want to reiterate it, there's not a one size fits all, right? Every one of these situations is unique, and it's very important to tailor any sort of recommendation specifically for each situation. But I do think that there are ways to help those children be around each other more comfortably and not feel like they have to be separated.
Yeah, and I just want to jump on that too. And just, I think there's a lot more to answer this question more specifically. I would ask a lot of follow-up questions. But something that just comes to mind is, are there times when they are able to be, together, spend time together, and the sound is not an issue, identifying those if they exist, and then just thinking about, like, can we be flexible about how those siblings spend time with each other? Is there a way to be together while both having their needs met at the same time? And maybe we just get flexible and adjust the way that looks. So it's maybe not the expectation that we had originally, where we can all be in a room together, no one's wearing headphones, or no one's using any kind of tools, and we're just in a room together. Maybe it doesn't look like that. Maybe it just looks a different way. So I think just adjusting expectations and being flexible about how, how the solutions can kind of modify the way that we interact with each other. Just being willing to do that. Did you have something, Marsha?
You are striking closer to the marks here. The situation, let's think about it like this. So one of the children has misophonia. It's interesting because lots of times one of their parents has some degree. There's a genetic thing going on here. So, but let's say there's this family and there's a sibling, a particular sibling might be the trigger. So now we have a very challenging situation where the innocent child who's just going along without misophonia doesn't understand why this sibling is now glaring at them all the time, jumping up, telling them to stop it. It's very confusing for children. And those changes in misophonia often happen very rapidly. And everyone is confused, and the parents are trying to coordinate the children and resume our regular life, and the regular life never returns. And that, or rarely returns, or sometimes returns. So what I have done is I have thought about this over long periods of time. And one thing I want to say just on a conclusion is it's very difficult to get children who have misophonia, and sometimes adults, to have empathy for other people. This is a very interesting question about misophonia. Sometimes they do later, they feel guilty or they're sad, but in the moment, they have a lot of blame they put toward the world. I've told you 74 times not to breathe near me. And the parent and the other sibling are confused because they need to breathe and they forgot and they're breathing. So this becomes untenable. But what my advice is very specific. Put together a situation where those siblings grow up with pleasant memories. Their memories are not always 100%. She hates me and he's bothering me. So plan activities. Good activities are bowling, hiking, kayaking, biking. Go do noisy things, swimming, where misophonia is less of a problem, and schedule a fun outing for John and Jane on Saturday afternoons, and deliberately put those times together so they can look back and say, we had fun when we went to the shooting range or whatever. I don't care, whatever part of the country you're from, put together a hobby that they do together that's noisy and fun, or a game night even can be fun as long as no one's eating, for example, and stop trying to push them back into the family model, because that's now an antique. We have to move on and figure out new places. We're going new places. So I hope that's helpful, because that's a very specific, even adult level thing. You think of things you can do with those family members that are your triggers, so you have happy memories at the end of your life. Honestly, you just can't cut it off or get upset because the old way is gone. I don't know if that's helpful.
Couldn't agree with you more, Marsha. Yeah. That's part of the flexibility, right? Is like, and the acceptance. We have this thing, we're dealing with this thing, we're dealing with misophonia. Now we know that. Now, how can we be together? How can we find ways to work with it? How can we live well with this? Yeah, I think that's a great suggestion.
So I was just busy off screen copying the Q&A section so that we can have a record of all the things that Marsha has been very busy in the background while we've been sitting here having a nice conversation. Marsha's fingers have been, very busy answering many questions that were posed in the Q&A. So thank you for all of that service that you performed, Marsha, and as well as tech and popping in to answer some questions. So we are going to wrap up here. If you would like a copy or listen to this again sometime, or if you want to refer this particular clinic to anybody that wasn't here today, it will be available on the Misophonia Association website. It's a free clinic, and it's a free, for you to download it or watch it. The videos from the conference, they have a small fee that covers the cost of all of the production that's gone into them. You can find those from all the way from the beginning, any of them you want by year or topic or whatever. There will be another clinic like this with different speakers, different panelists, a couple more times this year. And then, of course, we will have our annual convention in the fall. And we would love to hear from Anybody who has time to volunteer to help the association, or anyone who has time or ability to donate something to help us provide the services that we provide. The only person at all that gets paid anything for running this organization is we have a part-time office manager. And other than that, all the rest of us have donated our time for years and years. And we do it because we love this community and we want to be the best help that we possibly can be. And we can use your support in volunteering as well as contributing to the existence of the association. Yes, Marsha.
No, you're saying goodbye, so I just wanted to smile. And these things make me so happy because you can't get with Lisa and Caroline. You can't go there. Maybe you can't call them up and go for tea. You can't, you're so far away. We have people on here from Australia, all over the world. And yet you get to spend an hour and a half with these amazing professionals. And Jaelline, I'm just so happy. Thank you for giving up your Saturday morning. You have no idea how meaningful this is. 70 people today got to hear directly from you and Jaelline. It's fantastic.
Thank you all for participating. Thank you, Lisa and
Thank
Caroline.
you.
Very much appreciate you. And
Thanks for all you do, both of you. Thank you
to
so much, Marsha and
so
Jaelline.
Marsha, I think we're all done, and I copied the Q&A so you can end the Zoom call.
Okay, did you get the last 6 I just did?
I don't know.
Okay, well, you guys can leave. And I think that I've been told to keep it on record for right now till we figure that out. But goodbye.
I copied through 11:29.
everybody.
Okay.
Bye.
Bye, Lisa. Bye, Caroline.
Bye-bye. Thank you.
Thank you, everybody, for coming. They're kind of heading off. I think they can edit this out on this part, I'm pretty sure, but we got some really interesting people that came. There's a nurse that wants to get involved, maybe even doing nursing education, for nurses in training. There's some people that wrote about misophonia being presented in some very good settings in hospitals and stuff now. I mean, this Q&A thing was really fun, and it's a whole wealth of information in there.
Yeah, I see the last couple of answers that you have in here. I will get those down as well.
I know I'm not going to talk about them specifically, but I think most of the people have gone, a few listening in, but should I go ahead and stop the thing? I have to hit end. Let's see. No, that's
1 second to copy the few of those.
Those presenters were fantastic. Very good. Very much in their own opinions, their own, people are figuring out their own methods, and they've been doing it now for a while. So they're developing stuff, and that's perfect.
Yeah. Okay. Got it.
Okay. Should I say goodbye?
Then say goodbye, and I'll talk to you later, Granny.
Okay.
Grandma,
Bye.
what's your name going to be? Grandma? Are you Granny?
Nana. I'm a Nana.
Nana. Okay.
I'm a Nana. My grandmother, one of them was Nana. So my mom was a Gigi, but I'm a Nana. What are you?
I'm a Gaga.
Oh, Gaga. That's so cute. That's like, I think, isn't that Hillary Clinton or something? Isn't she a Gaga? No, that was Queen Elizabeth was a Gaga.
It was the first sound that it was first name one of them called me, so it stuck.
Yeah, that's the way it is.
All right.
Okay.
Bye,
Thank
everybody.
you.
Thank you.
Have a wonderful afternoon.